Dr. James McCormack is a professor of pharmaceutical sciences at UBC. He co-hosts a podcast program with an Alberta colleague and is a hockey player and a rollerblader. He has spoken extensively on the subject of patient medications and recently returned from a speaking engagement in Australia. He is now on sabbatical leave in his job, and therefore he's just like us. We're on sabbatical too. Dr. McCormack.
Well, thank you very much for the invite. It's a pleasure to come and speak with you guys today. One of the things that I'd like to do is talk to you about a number of medical myths and hopefully have some fun and engage you guys in some of the stuff that we're going to try and do today. So what I want to do is make sure that at the end you don't feel like this. We want to make sure that we want to try and provide you with information. That's okay, I won't hear that, thanks. And as was mentioned, my name is James McCormack and I'm a professor with the Faculty of Pharmaceutical Sciences. And if you're interested about some of the work that I do, as you're being told about some of the podcasts and so on, you can find them at that website. And I think it's really important that whoever gives a talk should let you know about their conflicts of interest. My entire salary comes through the Faculty of Pharmaceutical Sciences. I have received no honorary or research money from the drug industry in the last 23 years or so, which I don't think is a big problem. But again, you just should know. I make a little bit of money doing this premium podcast that I'll let you know a little bit about. And I make some iPhone apps and stuff like that. I don't know if anyone cares, but that's what I do. Pardon me?
How do you use the mic?
It is on. I can slide up. Can you make it a bit louder?
No, it's just louder.
And now is it louder?
No, that's on.
Is it? I'm actually better when you can't hear me. So as was mentioned, I do a podcast with a family physician buddy of mine, and it's called the Best Science Medicine Podcast. Just by chance, the abbreviations are BS. And the byline that we have for the podcast is BS without the BS. And what we try to do is we try to provide healthcare professionals and pharmacists and anybody who will listen to us with information about how to think about healthcare. Because exactly as Margaret was saying, there's a lot of stuff and information that really doesn't apply to a lot of people, and we try and give them that information. We've become very popular. We've become the most popular medical podcast in Canada, and for some reason in Portugal. No idea why we're popular in Portugal, but we are. And we're also in the sort of top 10 in a few other countries and so on. And we get about 25,000 of these podcasts down there, which is very cool. So what are my objectives? At the end of this, I would like you to be smarter. I don't know how smart. I'm sure you're all very smart, but we're going to try and make you smarter. And one of the things that I work on a lot is to help people become healthy skeptics. And not cynics. Cynics are boring. I bet you know some. Skeptics. And I want you to always ask, I wonder if this is really true. And I'm going to show you a number of beliefs that you probably believe right now. And I'm going to sort of talk to you about why not those are not true. And so, as I was saying, a core of skepticism is doubt. And I doubt most things. Not because I'm negative, but if I don't doubt things, I'm going to believe things that are really just not true. A cynic is someone who just doesn't trust anybody. They don't believe the government, they hate the drug industry, they hate everybody, and they're kind of boring. So one of the key messages that we're going to talk about, and what I talk about with healthcare professionals, is a concept called evidence-based medicine or evidence-based healthcare. And really all that means is that we try to get our healthcare professional to use the best evidence that we have. Sometimes it may be almost nothing. Sometimes it may just be opinion. An opinion is very valuable, but what we try to do is get them to understand the evidence, because believe it or not, we really haven't done very much of that in healthcare. The reason that you often will get prescribed a medication is because your doctor did it yesterday, and the person who trained him did it. Not necessarily because of all the evidence. So I'm going to give you an example of why we need evidence-based healthcare. This is the saga of King Charles II. That's what he looked like. And these are the final days of King Charles II. We think he died of malaria, but we don't really know. But we do know that the records for what happened to him were meticulously kept. And so he died in 1685. He was known as the Merry Monarch. That's why he was dressed the way he is, I guess. I don't know. So this was the beginning of the end for poor Charles. And I'm going to read it. On the morning of February the 2nd, King Charles of England was preparing to shave when he suddenly cried out in pain, fell to the floor, and started having fits. That sort of like can be a seizure, nobody really knows. But when you're the king, 6 royal physicians can rush in and administer emergency aid. It is well known that back then it was way better to be poor when it came to the medical system. And I'll show you why. The very first thing they did is they let drain cups, 16 ounces of blood. They then applied heated cups to the skin, which formed large round blisters to what they call stimulate the system. And they did that because they had evil humors in these people. No one really knew what evil humors were, but they wanted them out. They then let out 8 more ounces of blood. And if all the bad stuff wasn't in their blood, it was in their bowels. And so what they did is they induced vomiting to purify his stomach, gave him an enema to purify his bowels, and then he swallowed purgative to clean out his intestines. They then force-fed him a syrup of blackthorn and rock salt. They shaved his hair and put blistering plasters on his scalp, and the king regained consciousness. And one of the biggest problems we have in medicine today is the treatment seemed to be working, so they kept going. Because our bodies are miracles. They get better quite often on their own. The problem is we give a drug, you get better, people go, it was because of the drug, or it was because of the treatment, and often it's not that. So they kept working at it. So what do? They give another enema, just for fun. They then applied an irritant powder up his nostrils, more blistering plasters to the skin, and put powdered cowslip flowers to the stomach. Then they made special plasters from pigeon droppings and put them on his feet, and put him to bed. Has this been done to any of you guys? I'm just wondering, because it doesn't work. On Tuesday, Charles awoke and seemed much improved, and the attending physicians congratulated themselves and continued the treatment. So they let out 10 more ounces of blood by just opening both jugulars, which is some of your veins which you don't want opened generally. They gave him a potion of black cherry, peony, lavender, crushed pearls, and sugar. He woke again, had another fit. What worked before? Bleeding him. So what did they do? They bled him again. They gave him cinnamon pods and spring water and white wine with nutmeg. We think it was a Chardonnay, but it wasn't one before. They then force-fed him a drink made from 40 drops of extract of human skull of a man who had met a violent death. Then they made him eat a gallstone from an East Indian goat. And then they proudly announced that King Charles was on the road to recovery. When you have 6 royal physicians telling you you're on the road to recovery, it doesn't mean a lot. On Thursday, he was near death. He was blistered again, we bled, we purged, given another enema. He was given, at the time, a Jesuit powder, which was a controversial malarial remedy that had quinine in it, which actually had something that was of value for malaria. And he got the 2 drugs that I desperately want when I'm dying. Opium and wine. Preferably red. And I'm just thinking. And I love this. The doctors were mystified by his weakening condition. What's this patient's problem? Okay, well, the doctors, yes, but we don't want to be too mean to the doctors. What's his real problem? Yeah, he's got no blood. This is not a difficult diagnosis. You guys are making it just like that. But the 6 royal physicians 300 years ago didn't know what was going on. So on Friday, Dr. Scarborough wrote, and this just sort of shows the compassion. I just love this note. It starts off with the word, alas. And he goes on to describe the problem. But we'll go on with that. So showing no improvement, the king was bled almost bloodless. They scoured the palace grounds and created last-ditch antidote containing extracts of all the herbs and animals of the kingdom, mixed it with ammonia, and then poured it down his throat. And on Saturday, the king was dead. So if you were someone paying attention to this, you would have a tough time going, that kind of looks like torture. What's the difference between what I'm just showing you and torture? Intention, absolutely. This was all done with the best of intention. Most of your healthcare professionals do stuff with the best of intention. That's potentially a problem when they don't look at the best available evidence. And so what we try to do is encourage people to look at the best available evidence. Because I'm pretty sure, and in fact it may not be 300 years, it might be about 3 years from now, someone's going to be standing up here, and it may even be me saying, you know what, we used to lower cholesterol. And I can tell you right now, that entire cholesterol myth is absolutely on very shaky ground. It really is. It's quite an interesting concept. And we'll talk about that maybe as I go along a little bit. One of the things I like to do is include music in my clips. The job that you have to do is you have to tell me the name of the band. Who is it? Not the Who. Loving Spoonful. Very good. That's them. That's what they look like then. That's what he looks like then. So we have a number of beliefs, and you guys are going to know these ones really well. If you go swimming sooner than 1 hour after eating, what happens? You get cramps, and then what? Yes, and then you die. As with all good beliefs, you're dead at the end, right? So you get that. Who told you this? Your parents who love you more than life itself. How many of you actually told your children this? Come on, be honest. Yeah, it was wrong. Please don't do it. And just with a show of hands, how many thought it was an hour? Okay, how many thought it was half an hour? Okay, look around. Those people did not love their children nearly as much as the other people. So we know that this is not true. But why do we do it? Because we cared and we want to make sure to try and prevent things from happening. But it's just not true. What about here? You go outside in the cold with wet hair, what happens? Well, what's the first thing that happens? You catch a cold, and then you get pneumonia, and then what? No! You have to get double pneumonia first. Right? And then you die. One of the big problems about this is it's not true. But it sounds like a great story, and that's one of the problems in medicine is that we have these brilliantly good stories because people do get more colds when it's cold. But we think it has to do with viruses. So there are numerous belief things that are really just not true, and these are just a couple of examples. You can already see what it is, so if you don't know, please do not say the Who, because that would really be not great. So I couldn't think of a better song, and that's what he looks like then, and that's what he looks like now. Paul Simon. That's yes. So I could not think of a better song to introduce this next topic, and it's where do suppositories fit in? Now I would like you to think about. Now this is not a life-size suppository. Just so you might be a bit worried. Just with a show of hands, if you had to insert a suppository, how many would insert A? Just with a show of hands. Which direction? Just with a show of hands. This is the part of the interactive part. So how many, come on, people? How many would be B? Well, so that's a whole bunch of people who put up your hands. So what, are you going to put it in sideways? So how many would put it in A? Come on, you got to, thank you, that's what I wanted. Okay. That's what you'd have thought, because it says so on the label, and that's what you're supposed to do. In the Lancet, which is one of the major medical journals we have, there was a study that looked at this. This is science at its best. What they did is they got a whole bunch of people to insert suppositories. If they inserted the A end, 83% needed to introduce the finger. Do I need to explain what introducing the finger means? No? It's not, hello, this is my finger, just so you know. And there was a 3% expulsion rate when they did that. If they turned it around and inserted the B end, only 1% needed to introduce the finger. And there was no expulsion of the suppository, and 98% found the method easier. That, you're going to go home tonight and go, I learned absolutely nothing from this talk, but boy, I now have to insert a suppository. So in case you were not following, this is how you do it. You take the suppository, turn it around. Are you cheering for that, or are you cheering for George Bush? I'm not sure. Okay. So what about this one? How many glasses of water are you supposed to drink a day? Yeah, it's not 10. You'd have thought it'd be 10 because that's a nice, but 8. And you all know it, and it's absolutely not true. There's not a shred of evidence to support it. And so here's where it came from. It's not absolutely really clear, but apparently there was a couple of nutritionists either asked on a radio program or written something, and they were literally sort of asked it like this: how many glasses of water should people drink a day? And they went, 8. And that became such a powerful belief that you all know it's 8. And what's kind of interesting is people have tried to look to find out whether it is 8, and there was a guy who looked at every article he could possibly find about this, and this is what he found. There were absolutely no scientific studies that were found to support that. It's a complete belief, and in fact there's a suggestion that it's potentially harmful. We're going to get to some very common sense things. Guess when you should drink. When you're thirsty. That's a pretty good message, and we'll get on to some more difficult ones in a minute. Does coffee count as a source of fluid? Well, we got a yes and a no, and they're going to fight each other. Why is it no? Because it's a diuretic. What a great story, and it's absolutely crap. There's absolutely no, it makes no sense whatsoever. And in fact, caffeine drinks absolutely can be included into it, but because you've got such a good story, you can convince people, well, it's a diuretic. Here's an easy argument. You're on a deserted island. You haven't had water in 3 days. Someone comes up and says, would you like a cup of coffee? No. It's got a diuretic in it. No, thank you. That's ridiculous. What about this one? If you eat lots of carrots, you'll be able to see in the... You guys are full of beliefs. You're probably full of a lot of other stuff, but you're full of beliefs.
We can see it all.
So this actually came from the Second World War by a guy named John Cat's Eyes Cunningham, who was a top ace in World War II. And the carrot story was apparently propaganda fed to the Nazis to protect the secrecy of radar. Apparently, the Germans were so stupid. They said, no, the English said, no, we don't have radar. We're feeding our pilots carrots. That's why you're getting everything being bombed to hell, because we have carrots. Anyway, it's not true. There's not a shred of evidence to support it. But you all know it. What about this one? This one gets me into trouble all the time. Take the antibiotics until they're all gone, because if you don't, you will get... Yeah, and you get resistance is actually what it is, yeah. And then if you get resistance, you'll get what? Get it back. Some people say you get a super infection. Nobody knows what that is, but that's what you get. And then if you get a super infection, you will, of course you will, because it's a belief, and you die at the end of all beliefs.
What's this light in the middle?
So I want you to help me with this one. So
Turn it off, no?
what about this belief? The longer you take antibiotics, the greater chance of resistance, and then you get a super infection, and then you die. You can't, those are two completely different things. The best available evidence that we have for infections, and I'm not talking about HIV or tuberculosis, but if you have a pulmonary infection, or if you have a bladder infection, if you have a skin infection, the best evidence is that once you have no symptoms for about 2 to 3 days, you stop the antibiotic. But you know why it's such a powerful belief? Because we put a label on a bottle, and there isn't any evidence to support it. I know it's what the doctors tell you, and but the reason I'm saying this is because 6 doctors took care of King Charles II, and that was torture. So exactly the point that Margaret was saying is you've got to question things sometimes. But I understand how difficult that is to do. Because if I say you got to take it for 10 days, you're going to go, well, I guess he knows what he's talking about. But you know why a doctor prescribes antibiotics for 10 days? Because 9 would be stupid. Think about it. We don't prescribe for 8 days, but we do prescribe for 7. But not 6. Yes for 5, no for 4, yes for 3, no for 2, yes for 1. It's ridiculous, and we make up a lot of this stuff as we're going along. We'll get to questions. I know you, by the way, that's one question that always gets me in a lot of trouble, but the best available evidence, and if you don't believe me, there was an article in the BMJ written all about this, written by me, about that, so you can check that out. So here's another thing. Most things that are new are not better. as an educated person who's going in, I firmly believe that you should, if a doctor tries to give you a medication that almost without exception, if they try to give you medication that's not been on the market for at least 5 years, you should ignore it. It is because almost none of the new medications that come on the market are better. That's the problem that we have with new medications. Let me show you some of the evidence that we have. So that's absolutely true. We can talk about it. Not all new medicines, but the vast majority are not better than what we already have. And this is where it's getting very, very tricky. And so we'll start with this. So. Why is there sound? Should be sound on that one. Queen, very good. So what does that mean? It's your generation? Did you say your generation, dude? That's cool. That's Queen right there. And unfortunately, can we move this just down a bit so we can see the top of that? So this is the number. I sit on a group called the Patent Medicine Prices Review Board, and we look at all the new medications that come onto the market every year. And I've been doing that. I did it for about 6 years. And actually, if you look at all the new medications that come onto the market, and this is in the last 10 years, from 2000 to 2010, this is the number of drugs that we considered were a substantial improvement. It doesn't have to be brilliantly good, but it has to be substantial enough that it actually is something that might be useful. And over that 10 years, it was 19. I know it feels like more. Here's the problem. Half of those are for medical conditions you've never even heard about. So we, on average, get about one new medication every year that's better than what we had before. It is really quite unusual. It's about 1 out of 20 new medications that are an improvement. And so my usual premise is to avoid, almost without exception, new medications until they've been on the market for at least 5 years. With the caveat that if you've got a life-threatening condition for which we have no other treatment and a new drug comes out, you might want to use it. That's the trickier part. Interestingly, over that same 10-year period, from the FDA, 23 drugs were removed from the market. And the most common drugs that are removed from the market, interestingly, are anti-inflammatory drugs, NSAIDs, which you've probably heard. Not necessarily naproxen, but those types of medications. Interestingly, one of the drugs that we said was a breakthrough or substantial improvement became one of those. Another trial was done, so that makes you kind of nervous. And if you're wondering if we're the only people who say that, well, no, there's a French group that looks at all this, and they just looked at all of the most recent medications in the last year. And they didn't just say substantial, they said any improvement at all, even down to a modest improvement. And in 2011, it's the first time they've ever had to do that. There was not one medication put out last year that was an improvement over what we already had. In 2012, there was 2 that came out. One was, and they called it a modest improvement, one for prostate CA and one for Hep C. So this is one you need to know this. And it is a big problem. We don't have a lot of really great new medications coming down the market. We did maybe 30 years ago some really cool, useful medications, but we don't have a lot of new ones coming out. So I've sort of been a little bit negative, I guess, but many therapies really do work. So we have lots of really good medications. Antibiotics for moderate to severe skin infection. There's no doubt that they work. Beta agonists, if any of you have either asthma or you have COPD, and that blue inhaler, that's an amazing medication. It definitely works. It makes you less short of breath. We have steroid cream for eczema, which can really help a lot of people. We have opioids for acute and chronic pain. If I fall off here and break my leg, and I go to an emergency room, I want IV morphine, and I want lots of it, because it's an effective drug. Acetaminophen or Tylenol for osteoarthritis is an effective painkiller. We have definitely effective painkillers. We have diuretics, drugs that make you pee more, that are very valuable for heart failure, especially when you get into very bad heart failure. We have antibiotics for pneumonia, which can help. We have antivirals for HIV. I mean, when I started practice in 1986 at St. Paul's, our wards were filled with HIV patients, and now it's just not. It's quite amazing. And beta blockers for migraine. We have some really cool medications that reduce the chance of things for headaches. So this is just some example. We have some wonderful medications, but we have some that don't work all that well. Adrenaline if you have anaphylaxis. you can die from anaphylaxis. Adrenaline can prevent some people from dying. One of the biggest issues, and I think you sort of focused it on it a little bit too, is preventative therapies. These don't work nearly as well as you might think. How many of you, just with a show of hands, would skydive? Well, we got one crazy person, a few others. So how many would not? Holy cow, what a chicken group. This is just a big... So, if I was to equally train you well, and it was free, and all that sort of stuff, you had a parachute and so on. Maybe I didn't make that caveat. I was going to give you a parachute, not just jumping out of a plane. So, some of you would jump, and some of you wouldn't. Even though the chance of you dying at the bottom would be pretty similar. Why did some people say yes and some people said no? Well, you're either afraid of heights. It doesn't really matter what the reason is. It's personal preference. Here's where our guidelines, exactly as you say, fall down. We don't talk about patient values and preferences when we talk about healthcare. Because a lot of people will take risks and a lot of people won't. And all our guidelines say is your blood pressure must be 140/90, your cholesterol must be 2, your glucose must be, or your A1C, depending on what you look at, should be 7. And we never take into account that no one ever tells you about here's the benefit and here's the harm. Almost never. And I'm going to try and give you some of those numbers as we go through here. Because you're going to see things like this. This is a typical radio report. And have you seen things like this on your TV? Yeah. Please stop looking at these things. You cannot use them. They are misleading. They're not lies, but they are misleading. Let me show you why they're misleading. I talked about evidence-based healthcare. One of the most important parts of evidence-based healthcare is patient values. So we have evidence. We need to mesh your values or your parents' values or whatever, and we're making decisions. So I won't go too much. Oh shoot, did I miss I think I've got slides in the wrong order. That doesn't happen very often for me at all. I'm going to give you an example of how that works. So I'm just going to give you a show of hands. The way that we figure out whether a drug works is, I'm going to give you, let's say you've gone to your doctor and you've been told you have high blood pressure. How many actually had that happen? Okay. Or you've got high cholesterol or whatever. Let's say we're going to take you in and you're going to see your doctor. I have a drug for high blood pressure or high cholesterol. And what it does is, it's free and it causes no side effects. Now I know that's unusual, but let's say it does. I've got 3 different studies that are going to show, that I'm going to tell you about, and you're going to tell me whether or not you would take that drug every day for the next 5 years, and I'm going to give you a potential benefit. How many of you would take it if giving you the medication reduced your chance of a heart attack or stroke by 33%? It was free with no side effects. How many of you would take it? Okay, a fair number of you would take it. How many of you would take it if I could reduce your chance of a heart attack from 3% down to 2%? So instead of 3 in 100 getting it, down to 2 in 100. How many would get it for a 1% benefit? 1 or 2, maybe 3? Okay. How many people would take a medication every day for the next 5 years if it prevented one person from having a heart attack or stroke? 1 out of 100. How many would take it? We got one person, obviously a drug dealer. Just kidding. So I gave you some numbers of 33%. I said 3 down to 2, and I said 1 out of 100. Here's where it gets tricky. Those are all exactly the same numbers from exactly the same study. So you're probably going, no, they're not. Yes, they are. If you reduce your chance of a heart attack from 3%, so that's 3 out of 100, down to 2%, that's 2 out of 100. How much less is 2 than 3? It's 33% less. And 3 down to 2 is how much? What's 3 minus 2? 1%. What does 1% mean? 1 out of 100? Yeah. So that means 1 out of 100 people will benefit. That is the benefit for most people of taking a statin. It reduces your chance of a heart attack or a stroke by 33%. But what it really means is it goes from 3 down to 2. Which means only 1 in 100 people benefit from taking a statin if you've never had heart disease. Now, is that good or bad? What's ridiculous? I didn't say ridiculous, you said ridiculous. But if I was to tell you I could reduce the chance of a heart attack by 33%, a whole bunch of you would take it. But when I tell you it's 1%, almost none of you would, with the exception of our drug dealer here in the room. So, when you hear these sorts of numbers, you need to be asking your healthcare professional, is my risk going from 3 per million down to 2 per million? 0.3 to 0.2, 3 to 2, 6 to 4, because every one of those means 33% reductions. Why do we go to the professional? Because that's the system we have. We'd have thought so, but we'll talk about that for sure. I think what you should be going to the healthcare professional for is information to help you guide you to make a decision. You should not be going to be told what to do, which is a big difference. It's a change in how we think about healthcare. So that's why it's very important to talk about these sorts of numbers, because really the most important thing is when you're going to see a healthcare professional, especially when it comes to things like blood pressure, glucose, and cholesterol, you need to be asking, if I do nothing, what will happen? And we have the tools to give you a rough idea of the chance of you getting heart attacks and strokes. We have, they're not great, but they're pretty good. And then you need to ask, if I take this for the next 5 or 10 years, how much does it reduce it by? I think that's a really important concept. And in case you didn't follow some of these numbers, this is what they sort of mean. I want you to pretend you're walking down in a store, in a mall, and you come upon the dress. Not a dress, the dress that will make you the most stunning and amazingly attractive woman ever, even you. You hear it's 50% off. How many of you are going to buy it? Of course some of you are. What if it cost $1 billion? You're not going to do it, right? Because if you could afford it, you would, but most people can't afford $1 billion. So 50% off is exactly like what you hear in the news reports about 33% off. And I don't know if you can't quite see it. You need to ask off what? What is my chance in the first place? And if you cannot tell me that, how can I figure out what my benefit is? Because you might be told you're at high risk. Has anyone ever heard of a term like high risk? Yeah, you don't know what that means. High risk is just a scary thing to tell somebody. What they should be saying is your chance is about 10% or 15% and help you understand those numbers. And by the way, when you go on the sign, they all say up to on selected items, and that makes it very confusing. So I'm going to show you, by the way, this talk I give to many healthcare professionals as well. This is the way we look at studies to see if something works. Let me try and help you through this one. So, statins, you all heard, you said, you found out you're all on statins probably? Yeah. Good grief. Anyway, so this is what we know about statins. If you're 45 to 60 years of age, and we look, the way we figure out if something works is we give a whole bunch of people statins, or we give a whole bunch of people placebo, and then we follow them along and see what happens. If we do that for 5 to 7 years, and we give people placebo, these are the bad things: coronary heart disease, death, all deaths, and coronary events. Let's focus on the biggest numbers that's possible. If you get placebo, you have a 5%, so that's 5 out of 100 people will get a coronary event. They'll get angina, they'll get a heart attack, or something like that, okay? Following that so far? If I give you a statin, it goes to 3.3. You will hear that that's a 35% reduction in the chance of a coronary event. But the absolute difference is actually 1.7. 5 minus 3.3. In other words, you have to treat about 60 people with a statin for 5 to 7 years to benefit one. Some people say, well, am I going to be the one? I don't know. If I could tell you that, I would be making a lot more money than I am right now. So, this is a really important concept for you guys to understand, in that what you should be asking, if someone says, I think you should be on a statin, they shouldn't be saying, well, you should be on it because of your cholesterol. We now know that that's not as big a deal as we thought before. What you should say is, thank you very much. I just want to know, what's my chance of a heart attack in the next 5 to 10 years? And if you give me this treatment, what does it reduce it to? And if they can't answer that, that's tricky. Pardon me? I don't know if you need to find a new doctor, but you need to maybe ask other people and see if they can help you. It's a very tricky process, but we'll try that. No music again? Yeah, you saw the answer anyway, so you do that. I don't know where they're going to but anyway, that's what they look like then, and that's what they look like now. So first things first. And can you tell me how much longer I've got? It's now 3:12. 5 minutes? Okay, I'll be very quick. First things first. All the stuff I'm going to tell you right in the next 5 minutes has nothing to do with people who have really big high blood pressure numbers. They clearly benefit. This is not to do with people who have really high glucose numbers. They benefit, especially if they have symptoms associated with it. But I'm basically talking about the vast majority of people. How many of you heard Tom Hanks has diabetes? Did you hear that? Yeah, he probably has something that's not even important to treat. That's how, because he's just shifted over into just a number, and I'll try and show you what I mean by that. So it's really important to not know your risk. We focus way too much on these numbers, blood pressures, glucoses, and cholesterols, when we really should be focusing not on those, but on what's your chance of a stroke or a heart attack. Because that's the only reason we treat these things, is to reduce your chance of getting these sort of complications. And we do silly things. We call these things the silent killer. Is there anything worse? You're walking around, all of a sudden, you're dead and you didn't hear it coming. Well, we call diabetes the silent killer. We call osteoporosis the silent thief. You're walking around, someone steals your bones and you collapse. We have a thing called, anyone ever heard of the metabolic syndrome? Do you know that that's just the politically correct way of saying someone's fat? That's really all that means. And then we have, how many have pre-diabetes? This is made up stuff. Pre-diabetes and pre-hypertension is basically everybody. If you have blood pressure, you have pre-hypertension. These are kind of made up things, and you need to ask, what is the risk of all these things? So I'm going to give you some examples. And the whole concept is coming from a group of people who are talking about minimally disruptive medicine. And the minimally disruptive medicine is, how do we make your life not revolve around the medical healthcare system? Because it's not a lot of fun going to doctors. Present company excluded. So, I'm not going to go over these things because I'm running out of time, but we want to establish the burden of therapy. We don't want to make it too cumbersome. We want to make sure that we work with the right amount of evidence and we acknowledge comorbidity, which is a really important thing, especially for the frail elderly. Comorbidity, which is additional disease states. So, just so you know, and I'm happy to answer questions because I'm obviously going to run out of time a little bit. In the last 3 to 5 years, there have been 17 large randomized controlled trials, which are the best trials we have. And that's how we figure out that things work. 17 in a row that have shown no benefit from treating blood glucose, cholesterol, and hypertension. Almost all of those are people with just a little bit of elevated blood pressures and a little bit of elevated cholesterols. The really big numbers, they really benefit. This is a problem. We are over-treating a huge number of people for little bits of elevations of blood pressure and little bit of elevations of blood glucose. And these are, if you're interested, this is the names of all those studies. It is actually having a big impact, it's slow, on the guidelines. Some of the people that you were talking about in Nova Scotia, they've now changed some of the guidelines for type 2 diabetes. Where, have you guys heard of A1C for type 2 diabetes? Yeah. They're saying, it used to be that you had to get everybody below an A1C of 7. Now, especially if you're frail elderly, they're saying, if you're between 8 and 9, well done. You're actually alive. Good job. Because we lower people's glucose too much sometimes and they fall down. We lower their blood pressure too much and they fall down. So I'm just going to give you one example and we can maybe talk about a few more. And the BMJ is even talking about this, and they've just published an article, an entire journal about Let the Patient Revolution Begin. So believe it or not, this is a true statement. Less than 10% of patients will benefit when you treat blood pressure, cholesterol, or glucose over a period of 10 years. Now, it doesn't mean zero, but it doesn't mean everybody by any stretch of imagination. So if you have some elevated blood pressure, and you can take a medication and it doesn't make you feel yucky and it doesn't cost you very much and you don't have to become obsessed by measuring your blood pressure and so on, then maybe it's reasonable. And I'll just give you one example, and I can give you other examples later on. So I'm just going to show you one example of the potential benefit. So the way I like to explain things to patients is, if we take 100 people, this is 100 faces. The green faces are people who will not have a heart attack or stroke no matter what we do. The red faces are people who will have a heart attack or stroke even if we do something. These ones here are the ones who the treatment benefits. So let me give you an example. And this is over 5 years. So that's green, wouldn't have had a heart attack or stroke anyway. Red will have a heart attack or stroke despite treatment. And these are the ones who will actually benefit. So I'm just going to show you one example of high blood pressure. I could give you more for cholesterol and so on if you ask questions later on, but I'll just give you the one example and then you can get a feel for this. So, if you are aged over 60, none of you are, I'm sure, and your blood pressure is between 160 and 180, this is the benefit of treating blood pressure for 5 years. This many people will still have an event no matter what we do. This is the number of people who will not have anything happen to them. And these are the people who will benefit. How many people is that out of 100? 5. So, in other words, if we treat high blood pressure for 5 years in people over the age of 60, 5 will benefit, 95% don't. Now, if the treatment doesn't hurt you and it's inexpensive and all that sort of stuff, that's not bad, because heart attacks and strokes are bad. But if all of these people here, if these 95 who are not going to get a benefit anyway, have side effects and feel miserable and keep falling down because of those medications, that's a different story. And so one of the most important messages that you'll hear from me is, and by the way, this is as good as it gets. Statins are about 2 to 3%. Aggressive control of type 2 diabetes is now 0. That's a big problem. But again, I'm not talking about the big numbers. So the big issue, the only thing I'll just leave you with here is, it is so important to start with very, very, very low doses of these medications. Like, I often get teased when I say this, but what you should do is when you get a prescription bottle, you look at it for a week. Just feel the essence of what's in that bottle. Then open it up and then inhale the vapors for another week. And if it's not going to kill you tomorrow, start with a quarter of a tablet or just a little bit to see how your body tolerates it. So I'm sensitive to the time because I don't want to go over, and I could give you a whole bunch of different examples of things like glucose and blood pressure and cholesterol. But the most important question really is to ask, if I do nothing, you were saying you don't just do something, stand there. If I do nothing, what would happen? And then if I do the treatment, some of them will be fairly impressive, but the vast majority are not nearly as good, and we get fooled into thinking things like lowering salt is really healthy. The evidence is so poor that lowering salt improves any sort of outcome. What's that? All the food is full of salt, and it makes it delicious. And I'm not saying, so those are the main messages that I'm talking about. Most important, if you're looking for dietary advice, you eat the Mediterranean diet. That's the best evidence that we have. You get lots of activity. That's way better than any drug. And don't smoke. If you do those 3 things, that you cannot do much more for your health than that, unless you have really big numbers. Anyway, thank you for listening.